Good afternoon. My name is Federico Velez. I'm one of the pediatric ophthalmologists here at Jules Stein Eye Institute, and I'm going to give you a review on pediatric ophthalmology. I'm going to just start with abnormal visual acuity in kids. So we have congenital and acquired visual acuity loss. So if we have a congenital visual acuity loss, the first thing to do is a good examination. A little coma, maybe a congenital corneal opacity, sclerocornea, cataract, glaucoma. All these can give you visual loss in a newborn. Microphthalmos, albinism due to macular hypoplasia, optic nerve hypoplasia, and aniridia. If the anterior segment is normal, and I use these diagrams through my lecture, so probably will help us a little bit more to follow up the whole idea. We check the pupil. Of course, an afferent pupillary defect will probably point towards the optic nerve, and a paradoxical pupil will give us the idea that maybe the problem is the retina. If the pupils are normal, then we look at the retina and we try to find out if the problem is a retinopathy. Remember that Leber's congenital amaurosis, we don't see any abnormalities in the retina, and the fundus examination is completely normal in a baby, probably in the first 6 months of life. Those kids have usually very high hyperopia, and later during infancy they can have peripheral retinal pigmentary abnormalities. But in the first 6 months, usually there are completely normal examinations. Optic nerve abnormalities, the most important one to remember in pediatric ophthalmology, optic nerve hypoplasia. And subtle forms of hypoplasia sometimes are not recognized. So if the fundus examination is completely normal, then basically we have few diagnoses. One, I just mentioned, Leber's congenital amaurosis. Number two, delayed visual maturation. Number three, cortical blindness. Ocular motor apraxia, which is a rare entity. The problem with ocular motor apraxia is that the patient is unable to start saccadic movements. So when you present objects to the patient cannot follow them because he's unable to start the saccadic movements. So the patient will be able to look at them by moving the head, but if he's a baby, of course, that's limited. So a good way to identify this patient, just check the pupil, the reaction to the light, just don't look for movements to objects or following movements and during your examination. Bilateral visual acuity problems. The number one that you have to rule out in pediatric ophthalmology is amblyopia. And amblyopia caused by bilateral high refractive errors. And the most important one is astigmatism followed by hyperopia. Myopia usually is pretty benign in kids unless they have, I would call malignant myopia, patients that have, progressive myopia, never corrected, but usually they have in the first months of life good near visual acuity, which is important in these babies. In the presence of an afferent pupillary defect, amblyopia can also give you an afferent pupillary defect, but we're going to be looking more to the optic nerve, of course. In a paradoxical pupillary response, then we probably have either cone dystrophies or congenital stationary night blindness. Those probably are the most important diagnoses. Delayed visual maturation. So it's a kid that looks like he's blind. In the first 3 or 4 months of life, the patient does not respond well to light stimulation or objects, and usually lasts 6 months, but is normal up to 12 months of life. Remember that. If the patient is completely normal, doesn't have any neurological problems, and doesn't have any other ocular abnormalities, you don't need to do any workup. It's very commonly seen in patients that were born prematurely. There are 3 forms of delayed visual maturation. One is isolated. The other one is associated to other ocular abnormalities. In those patients, probably you don't know what is going to be the visual prognosis. But when you have patients that have other systemic abnormalities, especially when they have hydrocephalus, there was history of hypoxia, anything like that, seizure disorder, those patients need to be imaged. Don't wait to the 12-month period when you consider is normal or abnormal to image those. So that's the only indication to do imaging study on delayed visual maturation. It's usually also associated with other delays, and delays in the visual evokate potential, auditory evokate potentials too. This is what I just mentioned. So the differential diagnosis will be, of course, Leber congenital amaurosis or cortical blindness, especially in patients that have no other findings. Acquired visual loss. So the most important ones, uveitis and trauma. Vitreous hemorrhages or optic inflammatory conditions. Those are the most important for acquired visual loss, and if it's acute onset. When it's chronic onset, the most important is probably cataract, optic nerve atrophy. We're going to talk a little bit later. So I basically will point these two entities, cataracts and optic nerve atrophy. Of course, amblyopia, but we're probably past that age here. Amblyopia, 3 forms of amblyopia. I don't think Ken Wright will talk about amblyopia later, so let me just talk a little bit to you. One, the most common one will be refractive amblyopia. And I will mention in a minute something. Number 2, strabismic amblyopia. And number 3, deprivational amblyopia. The typical for deprivation is cataract. Strabismic amblyopia can happen anytime. For refractive or amblyopia, these are the values that I want you to remember. So the most common one will be anisometropia. And anisometropias of more than 1.5 diopters of hyperopia and astigmatism would be high enough to give you amblyopia, unilateral amblyopia. If you have hyperopia, more than 3.5 diopters in both eyes, you can have bilateral amblyopia. And when you have astigmatism, more than 1.5 diopters in both eyes can give you amblyopia. This is important when you're evaluating pre-verbal kids. So I think just for your board examination, just remember that more than 1.5 diopters of difference between the two eyes may be high enough to create refractive amblyopia. Non-accidental trauma. It is important because eye exam is positive in almost 0.5% of the patient. And what I would like you to remember is this picture. This is the typical finding on a patient with non-accidental trauma. Multiple, multi-layer retinal hemorrhages. The most important differential diagnosis in the first 3 months of life is that birth can cause retinal hemorrhages, but those usually clear up after 3 weeks. The ones that we see in, of course, trauma, there's a later and they stay much longer. Vitreous hemorrhages actually are much later findings. So other findings commonly seen in patients with trauma, retinoschisis, retinal falls, and of course retinal detachment. You don't see that in birth trauma. Lens disorders. So pediatric cataracts. So let's talk about unilateral cataracts. These are the 4 most common causes of pediatric unilateral cataracts. The most common one is idiopathic. The second one is probably persistent fetal vasculature, or PHPV. Third one is trauma, and the last one is rubella, although rubella is usually bilateral. By far, this is the most common one, idiopathic. For bilateral cataracts, the etiology is a little bit different. Idiopathic is still the most common cause of bilateral cataracts. The second one is autosomal dominant. Genetic cataracts caused by syndromes is the third one in the list. And then you have all the other ones. Well, we just mentioned this. Chromosome Down syndrome is a very common cause of pediatric cataracts. They're usually acquired and progressive. And most of the cataracts that we mentioned here are actually non-congenital cataracts. It's not common to have congenital cataracts. It's more common to have acquired cataracts. And I don't use the term congenital cataracts unless I see the cataracts on the day the baby is born. From this slide, I always point out these two conditions because they're part of very likely your board examination. This, low, and this, Rubinstein-Tybee. Because these two conditions and rubella are probably the only three conditions that will associate two diseases: pediatric cataracts, likely congenital, and congenital glaucoma. So remember that: Lowe syndrome, Rubinstein-Tybee, and rubella, glaucoma and cataracts. Metabolic galactosemia. These two make a good difference between two very important conditions. When it's due to transferase deficiency, these patients have severe systemic disease. But this is a reversible condition if it's identified early in life. The cataract is called oil drop cataract. I don't have any pictures. But if it's identified early in life and the patient is treated with diet, you can prevent all the complications associated to galactosemia. Galactokinase deficiency is a very mild condition. It may not even cause cataracts. Infections, the most important, probably not for us in this country, but in other countries, is rubella. It's still a very important cause of bilateral cataracts, even though we mention unilateral, but it's usually bilateral asymmetric cataracts associated to microphthalmos, retinopathy, deafness. Toxic radiation, they're usually late onset. Patient that any kind of head radiation, usually the cataract onset is about 2 years later. And laser photocoagulation is important because premature kids have the tunica vasculosa lentis is very prominent, and that can absorb the laser. So there is a heat trauma to the lens that can cause a cataract. The other mechanism to develop a cataract in an ROP is, of course, direct trauma to the lens. So those are the two mechanisms to have cataract. Usually the cataracts that are caused by the laser are transient, and when it's not direct trauma, just the burning from the laser being absorbed by the tunica vasculosa lentis, they get better. Cataracts are divided in limited to an area, which is zonular cataracts, total cataracts, polar, and others. Let's just divide them. Nuclear cataracts. Nuclear cataracts are usually associated to microphthalmos and glaucoma. They're asymmetric. Lamellar cataracts have much better prognosis. They're also bilateral cataracts. This is a nuclear cataract associated to microphthalmos, usually bilateral but asymmetric. This one here is a lamellar cataract. So it's just one area of the lens that is involved, but the central part of the lens is clear, even though for you and this view looks like it's opaque. It's actually just like an egg that is covering a clear central nucleus. This is called a sutural cataract. You can see that the suture is what is involved. These cataracts are frequently associated with peripheral opacities. I don't have a picture, but this is the typical appearance of the lens of the mother of a baby with Lowe syndrome. So if you're suspicious of Lowe syndrome and you test for amino acid in urine and you're really suspicious of Lowe syndrome, it's important to dilate the mom and check the peripheral part of the lens. They have some specks on the peripheral or peripheral opacities on the lens when you do a dilated exam, similar to what you're seeing here. Polar cataracts. Anterior polar cataracts are usually associated, if not, I would never say always, but almost always, to persistent pupillary membranes. Posterior polar cataracts have a name, what is called posterior lenticonus. And posterior lenticonus is usually an acquired asymmetric cataract. And of all the pediatric cataracts, is usually the one that is associated with the best visual prognosis because it's a late onset cataract. And the mechanism for posterior lenticonus, which you're going to see many in your career as ophthalmologist, is probably weakness of the posterior capsule or traction from the vitreous, pulling the posterior capsule posteriorly. That creates an opacity on the lens that is anterior to the posterior lenticonus. This is a posterior lenticonus type of cataract. Anterior lenticonus, you have to rule out Alport syndrome, not with posterior lenticonus. Total cataracts, usually we see this in patients with rubella. They're bilateral, they're progressive, and they're associated with microphthalmos. PFB or PHB is usually, remember, unilateral. However, 20% of the cases are bilateral, and it's divided in two. It's divided in anterior, PHPB or PFB, and posterior. The anterior PFPB is diagnosed by microphthalmos, so microphthalmos or microcornea, hyperplasia of the ciliary processes. There may be a cataract, but what really you see is a membrane that is posterior to the lens, that is part of the hyaloid artery coming forward. This here has a name. So anybody knows this? The name of this? The membrane that you see behind the lens? Mittersdorf. So this, which is very vascular, you're going to see it on patients with PHPB. And that can be just the opacity. The lens can be completely clear. What happens is that the ciliary processes, they're hyperplastic, and they're like pushing the lens posteriorly. So other finding that you frequently see in PHPB or PFB is a subluxation of the lens. That's anterior. And anterior PFV, is usually associated with better visual prognosis. Posterior PFB has much worse visual prognosis because the most common finding is a tractional detachment of the macula. You see this hyaloid vessel coming out of the papilla that is pulling the retina forward and can cause a retinal detachment. So when we have a patient like that, we usually abort the surgery. We don't do any surgical procedure because the prognosis is very poor. The other thing to mention is the hyaloid vessel is frequently vascular and can cause a complication during the surgery, which is massive vitreous bleeding, that in a baby probably is worse than the cataract because vitreous hemorrhages in baby don't clear that fast, and they can create deep amblyopia. Okay, in membranous cataract, that's the last one that I wanted to mention, and rubella, like this. So how do we work up patients? So just remember this, unilateral cataracts don't need workup. Bilateral cataracts need to be worked up. And this is what I'm mentioning here is the workup for a bilateral cataract. So the first thing is pregnancy. Second part is family history, because we know that the second most common cause is autosomal dominant. And then we look for trauma. During the ocular examination, we want to identify the causes. Most of the time, we can easily diagnose PFB. But remember, nuclear cataracts can be unilateral and can be associated to microphthalmos. So not every patient with microphthalmos has PFB. It could be a monocular cataract, or it could be a bilateral PFB with microphthalmos only in one eye. If we cannot identify the cause during our ocular examination or during the general examination, then we should do what is called the pediatric systemic evaluation. And what is that? It's basically this. We do, of course, with the help of the pediatrician, we want to do genetic evaluation, metabolic screening, chromosome analysis, and then we can find out probably a lot of the causes. If everything is completely normal, including the metabolic screening, then most likely we're going to have an isolated cataract. So just to summarize, if your examination cannot give you the reason for the cataract, if it's a bilateral cataract, send your patient to the pediatrician to do a metabolic screening, send your patient for a genetic evaluation, and they can at least test chromosome, and probably, if everything is normal, you're going to be diagnosing an isolated cataract. Differential diagnosis of a cataract, leukocoria. Retinoblastoma is probably the most important. Toxocara is also a very important diagnosis, retinal detachment. Indications for surgery. Memorize these ones. These are, we as pediatric ophthalmologists use these. The size, the location of the cataract, and if you can see the posterior pole without dilating the pupil, and you can see details, it's likely that the patient can also see well looking through the cataract. Cataracts that are larger than 2.5 millimeters and cataracts that are posterior are usually more visual, compromise the vision. Those that are smaller or anterior usually don't. If you can measure the visual acuity, of course, if you have amblyopia, and if the visual acuity is worse than 20/70, you should consider doing surgery. What is the treatment of choice? The treatment of pediatric cataracts is basically this: lensectomy with primary posterior capsulotomy, because the posterior capsule becomes opaque in all patients under the age of 5 years. So we do capsulotomy because it's very difficult to sit these patients on the slit lamp to do a JAK laser capsulotomy. What do we do to treat these patients postoperatively? Well, I think for your board examination, especially those taking oral boards, you can probably suggest that after the age of 2 years, it's safe to place intraocular lenses. New evidence indicates that it's very unsafe, or not unsafe, let me use the right word. The incidence of complications is much higher in babies under the age of 6 months that are implanted with an intraocular lens when compared to a contact lens. So under the age of 6 months, contact lenses have benefits over intraocular lenses. We don't know what happened between the ages of 6, or in this case 7 months, and 2 years. For me, the standard is after 1 year, I put intraocular lenses. If I have bilateral cataracts, after 1 year, if it's monocular cataract, probably after the age of 9 months, I put intraocular lenses. The most important postoperative complication for you to remember is glaucoma, because this is life risk condition. So all these patients need to be followed up for the rest of their lives because they have risk to develop glaucoma. There are 2 types of glaucoma, aphakic glaucoma, okay? One is immediate, usually is an angle closure glaucoma. And the second, which is the most common one and the most important, is an open angle glaucoma. It's the most important one. Okay, let's talk a little bit about other lens conditions, dislocated lenses. So, ectopia lentis, simple, is usually bilateral, symmetric, superotemporal. It's autosomal dominant. There is one that is called ectopia pupillae. Basically, the pupil and the lens move in opposite directions. So this patient is basically aphakic. Let's go to conditions that we're seeing for sure. Marfans. So Marfan, of the following, two of four will help basically to make the diagnosis. Chromosome 15 is the abnormality, the same as another condition that we're going to see in a few minutes. So we have cardiac abnormalities, including aortic dilation, mitral valve prolapse, aneurysm. Ocular abnormalities, basically the iris surface is flat, and we have the lens dislocation. Here, hypoplasia of the iris transillumination, and the dislocation of the lens that usually is upward, temporal upward, with a very characteristic finding that will help you to make a differential diagnosis. Remember this. The sonal is stretched, but is intact. In homocystinuria, is broken. So when you look in the slit lamp, there are big differences between when you look the sonular ligament. It's a stretch in Marfan, but it's complete. In homocystinuria, is broken. Skeletal abnormalities and family history. Two of these would basically clinically make the diagnosis of Marfan's, like in this patient. With the dislocation, of course, I don't think we can even see sonor being stretching here, but let's imagine that that's true for sure. Homocystinuria, autosomal recessive, chromosome 21, diagnosis in urine disulfides, and basically these are the criteria for diagnosis. They're very similar to Marfan, tall patients. They also have dislocation. They have thromboembolism, but they have something that is important. They have mental problems. All these can be prevented, like in galactosemia, with early diagnosis. If these patients are treated with diet early in life, even the dislocation of the lens can be prevented. And it's very important to make the diagnosis before you put this patient under general anesthesia, because patients with homocystinuria need to get extra fluids, otherwise they get dehydrated and they can get thromboembolism and strokes. So this is a patient that actually has a confirmed homocystinuria. And if you see, the lens is all retracted. One is temporal, the other one is temporal. This eye is aphakic, this one is phakic. And this is broken here. Well, Marquesani. This is also located in chromosome 15, like Marfan. However, the patients with well Marquesani, they're totally different from the patient with Marfan. So remember, even though it's in the same chromosome, they're actually the opposite. They're not tall, they're very short, they're not skinny, they're a little bit more chubby, so like this patient. And the lens is small, and the dislocation is anterior. They have microspherophakia. You can see this lens here. It's in the anterior chamber, and these patients have angle closure glaucoma, and that's the most important complication. There are other causes of dislocated lenses, including sulfide oxidase deficiency, causing scissors and hemiplegia, and, well, others, but that's probably all I've seen in my life. And the workup is similar, and we already mentioned the direction of the soul luxation, your examination, physical examination, including heart, ultrasound, I assume, urine and blood, and chromosome abnormalities. The treatment is optical correction and removal of the lens. And if you remove the lens, there are different options. It's not really the reason for this lecture. However, you can fix lenses. You can use rings, but you have to still fix it because it's an unstable position for the lens. Let's talk a little bit about glaucoma, pediatric glaucoma. So, the cause of pediatric glaucoma is a trabecular dysgenesis. Autosomal recessive is probably the most common etiology, especially Middle East, but it's multifactorial. And we're gonna, let me advance this slide so we can actually go to what is characteristic of pediatric glaucoma. One, ocular enlargement. That's not typical of adult patients. That happens because the eye is immature. The sclera is very elastic. The cornea is very elastic. So they have buff thalamus, and when the glaucoma happens in the first 3 years of life, you have an enlarged corneal diameter. Later is an axial myopia. So that's number one. Now, due to the pressure and the stretching of the cornea, we have ruptures in the descendant membrane, have stria that they're usually horizontal. More vertical breaks and descendant are usually related to birth trauma. That's a good way to make a differential diagnosis. Well, we mentioned that here. Reversible optic nerve cupping. That doesn't happen in adult patients, and it can happen in kids before optic nerve atrophy. Let's work a little bit on the differential diagnosis. Enlarged cornea, megalocornea, which can be congenital, and one of the entities that we need to rule out is osteogenesis imperfecta, which can be also associated to melanosis oculi. Those patients don't have splits or breaks in descent. Corneal splits, I think the most important differential diagnosis for you, birth trauma. Corneal edema, congenital, for example, congenital endothelial dystrophies, which is probably the most important diagnosis, differential diagnosis in a cloudy cornea like this one. Trauma too. Tearing, nasal lacrimal duct obstruction. Remember, these patients with congenital glaucoma will have intense photophobia, corneal cloudiness or haziness, ophthalmos, and teary eyes. But it's more common to have nasal lacrimal duct obstruction. So probably the most reliable test that can confirm, you put everything together, probably the diagnosis is not that difficult. But if you want to really make a final diagnosis, if you instill fluorescein on the fornix and you introduce a cotton to the nose, to the nostril, or even a piece of Kleenex, and you recover fluorescein, that's not a nasal lacrimal duct obstruction. That patient has likely tearing from glaucoma. Optic nerve cupping, large optic nerve, which can be a congenital anomaly. And these are the most common causes. PITs, I think I may have a picture of a PIT later. Optic nerve coloboma, which is basically the absence. We're going to see a picture in a minute. Periventricular leukomalacia, which is, in my opinion, the most common cause of pale optic nerve in an ex-premature kid. And they don't need to be worked up. You can get MRI and CT scan, especially if there are delays, but if the kid is okay, that's the most common cause for it, periventricular leukomalacia. Now, let's talk about primary and secondary glaucoma. The primary glaucoma is basically the one we just referred to. Trabecular dysgenesis, first trimester pregnancy, that's probably when it happens. And sporadic, autosomal recessive, especially Middle Eastern countries. You can see peripheral anterior processes and basically a membrane covering the trabecular meshwork. The treatment of primary congenital glaucoma is surgery. You can treat the patient with medication, especially if the cornea is edematous, to obtain good visualization of the angle, but the treatment is surgery. And the treatment of choice is goniotomy. Now, when we cannot see the angle because the cornea is very hazy, the treatment of choice is trabeculotomy. That's for primary. Secondary glaucoma, these are probably the list of the most important conditions. Anterior segment dysgenesis. We're going to talk about them in a few minutes. There is a risk of glaucoma in about 50% of the patients that have syndromes, which means it's not only the eye that is affected. These are patients that have Axenfeld syndrome, not just an Axenfeld anomaly. Because if it's isolated, it's probably unlikely that they're going to have glaucoma. So if you have a patient with anterior segment dysgenesis, and on top of that has some skeletal abnormalities, teeth abnormalities, that patient probably has 50% risk of developing glaucoma. We're going to talk about probably aniridia. Well, aniridia is here, and we're going to present it in a few minutes too. So the workup for congenital glaucoma is basically looking for primary condition and a secondary glaucoma. And we already mentioned the treatment. So I'm just going to move forward. Of the medications that are safe to be used in pediatric ophthalmology, these are the list. Beta blockers, usually we use 0.25%. Topical carbonic anhydrase inhibitors, they're very safe and well tolerated. and Diamox is also very well tolerated in pediatric ophthalmology. Don't use alpha agonist. Alpha-GAN is contraindicated in pediatric patients, and probably iopidine. The reason is that alpha-GAN crosses brain barrier, and these patients become somnolent and depressed. And the same thing will happen with iopidine. The surgical treatment, I think I want you just to remember goniotomy and trabeculotomy. The rest of the treatment is the same as adults. Dr. Giacconi will talk to you on Sunday about that, so I'm just going to move forward. Anterior segment dysgenesis. So I think a good way to memorize this is that the simple one is just an anteriorly displaced Schwab's line, which is going to be a posterior embryotoxin, just like this. Very common finding. When this is associated with systemic involvement, like I mentioned, it's called syndrome. Now, this embryotoxin associated to pupillary abnormalities, like you see here, this is very dramatic, and it doesn't need to be this much. It can be just like a secondary pupil or a pupil that is drag. This is what is called Rigert's. So you have the axanthal abnormality, which is the embryotoxin, plus the iris abnormality. That's basically Rigert's. And then we have the last one, which is Peters. And the Peters is an absence of one area of the descent with synechiae or attachment, basically, between the iris and this area of the cornea. So that's basically Rigert's. It usually causes a white cornea. There is something called the von Hippel ulcer, which is that area of the cornea that is missing the descent, and can also be associated with glaucoma. And the last one is iris hypoplasia. This is another anterior segment dysgenesis. Aniridia. 1 in 60,000 newborns. This here is the lens. The picture is, first time you see it, is kind of hard to understand, but here is the lens. This is a cataract, and this is what is remnant from this iris. This is actually very common. I would say that most of the patients with aniridia will have a little bit of iris. And this is probably one of the reasons why these patients are at risk for secondary glaucoma, because this iris is very floppy, and it can move anteriorly and block the trabecular meshes. So it becomes like a secondary glaucoma. 85% is familiar, and this is probably the most benign one of all the two forms, because the one that is sporadic can be associated with Wilms tumor. What do we see in patients with aniridia? Of course, aniridia, but corneal panos is important, especially because patients may need to wear contact lenses, and it's very hard to fit contact lenses. Cataracts, they're progressive. Foveal hypoplasia. This is the most important reason of decreased visual acuity in patients with aniridia. Foveal hypoplasia. And this is the reason for nystagmus. 70% of the patients will have glaucoma. Because of that, some people promote prophylactic angle surgery in patients with glaucoma. Not too many, but just mention because I think it's important for you to know that. So the workup and the treatment for a patient with aniridia is basically try to find out if it's sporadic or not, and we have to follow up the patient with abdominal ultrasound. The pediatrician needs to know, because the Wilms tumor can happen anytime. I have probably 3 patients with Wilms tumor. And the treatment is basically the complications. If it's a cataract, probably need to remove the cataract, but assessing the visual acuity is very complicated because they have nystagmus due to the macular hypoplasia. And the glaucoma is probably the most important complication that you're going to face in patients with aniridia. These are just some congenital corneal abnormalities. Sclerocornea, which is basically the cornea that is opaque, frequently seen associated to microphthalmos. It's just like a continuation of the sclera. You don't see well the limbal area. Megalocornea is more than 12 millimeters. It's usually X-linked. Ophthalmos we mentioned. Nanophthalmos. Nanophthalmos is a very short eye. And the nanophthalmic eye is very important because the content, different from a microphthalmic eye. The microphthalmic eye is a small eye, so everything is small. But the nanophthalmic eye is a short eye with basically everything inside normal size. So those patients are at risk of glaucoma, angle closure glaucoma, but especially misdirectional or malignant glaucoma. For those treating adult patients, it's important to know that. Of the congenital opacities, trauma, glaucoma, congenital endothelial dystrophies, which is one of the most important for differential diagnosis with congenital glaucoma. Basically, the cornea is very thick. Uveitis, just juvenile idiopathic arthritis or rheumatoid arthritis, patients that are younger than 16 years old. Oligo or pauci-articular disease, positive ANAs, female patient. Intermediate uveitis or pars planitis is usually bilateral, associated to vasculitis, cystoid macular edema. In older kids, I think the most important diagnosis to rule out is multiple sclerosis. Adult, in this case, will be adult. Toxocariasis is an important cause of vitritis and ophthalmitis. You have a peripheral granuloma, and one of the most important differential diagnoses will be with PFB because of the retinal fold. The other differential diagnosis is a congenital retinal fold, basically a fold that is emerging from the optic nerve, coming anteriorly or going towards the peripheral retina. Usually when you have toxocara, at the end of the fold, there is a granuloma. And the way to diagnose is ELISA or eosinophil count. Let's move to optic nerve abnormalities. So in optic nerve abnormalities, bilateral optic nerve abnormalities usually are associated with poor visual acuity and nystagmus. Unilateral sensory strabismus. Small disc, the most important, hypoplasia, we're going to talk in a little bit. They're usually associated with midline defects. Large disc, like morning glory, they're associated with encephalocele and colobomas, systemic syndromes, and maybe golden heart disease. So let's talk a little bit about congenital abnormalities. Small optic nerve, we have hypoplasia, we're going to spend some time on that, and segmental hypoplasia. So, optic nerve hypoplasia. When you have an optic nerve hypoplasia, the most important is this. Not every patient needs to get an MRI, but if you have an optic nerve hypoplasia, every patient should at least get endocrine workup to rule out hypopituitarism. Segmental hypoplasia, I have a picture of that, usually is the kid born of a mother with diabetes during pregnancy. So optic nerve hypoplasia, remember this, septo-optic dysplasia, or also called de Maizière syndrome. This is basically a midline defect associated to hypopituitarism and optic nerve hypoplasia. And this is probably the order of hormone abnormalities. Growth hormone is the most common one that gets affected. Second, thyroid, adrenal. Visual acuity is very variable. And on fundus examination, I don't know, probably you all have seen optic nerve hypoplasia. At USC, there is actually a nice paper that was actually describing how to know if an optic nerve is small or is normal in size. So if you measure the optic nerve diameter and you can fit more than 4 optic nerve diameters between the optic nerve and the macula, that optic nerve is small. So that's one way to know if the optic nerve is small or not. The other thing that you have to look is the disposition of the blood vessels. The temporal arcade vessels, they don't emerge from the optic nerve going temporal. They actually go nasal first, and then they redirect temporally. That's called situs inversus, and is characteristic of optic nerve hypoplasia. And the other thing that you probably have seen is called the double ring sign, which is probably what your textbooks mention all the time. The Mosier, basically a genesis of the corpus callosum, septum pellucidum, and optic nerve hypoplasia, and pituitary gland could be absent. Segmental hypoplasia, an inferior, usually it's an altitudinal defect from a mother with diabetes. Excavated optic nerve. So main differential diagnosis with glaucoma, and let's see some examples here. This optic nerve, which looks like has a huge cupping, is very different from this optic nerve here. This optic nerve has no neural tissue. This is an optic nerve coloboma. You have all this peripapillary atrophy. This is very different from this optic nerve that basically is a huge papilla, is pigmented, and when you see this on a three-dimensional view, this optic nerve that can be completely normal in size is deeply located inside of this huge papilla. This is called morning glory. They're very different. This one has no tissue in the middle. This one has glial tissue right in the middle. The blood vessels here seems to be coming out in a normal fashion. The ones from here, they're radial. This is morning glory. This is an optic nerve coloboma, and they're very different. When you have a morning glory, one of the tests that you can do is you can do an angiogram, because some of these patients will have a moya abnormality, which is a vascular abnormality. PITs, usually temporal, they can be associated with serous detachment and serous-retinal arteries. And megalopapilla, which is a healthy optic nerve, usually is familiar, and it's just a large optic nerve with probably a normal size cupping. Pseudopapillary edema, so we have optic nerve drusen, I think that I have in some pictures here. High hyperopia is probably the most common cause of pseudopapillary edema. These are very small optic nerves, and they're crowded. Optic nerve drusens, very common in pediatric population. And myelinated nerve fibers. When they're associated to amblyopia and a high refractive error, is, for us here at UCLA, probably important, is called the Stratsma syndrome. It's by Dr. Stratsma. He described it first. Optic nerve atrophy, usually due to compression or trauma. Toxic or hypoxia in premature babies. Optic nerve atrophy, Leber atrophy is probably, well, the most important about this kind of atrophy is that it's rapidly progressive and bilateral. It's a mitochondrial mutation and is inherited from the mother. The visual acuity can be as bad as 2400. Shared dominant optic nerve atrophy is the most common and is slowly progressive. The visual acuity is not as bad as with Leber. Craniofacial malformations, golden hair. So golden hair is characterized by eyelid colobomas, preauricular tags, limbal dermoids, ocular motility abnormalities. Waardenburg syndrome. Most important is this: iris heterochromia, deafness, and white forelock. They can have other manifestations as skeletal, but just remember this one: iris heterochromia and deafness. Pierre-Robin sequence. So in these patients, the most important, high myopia, differential diagnosis with Sticklers. In patients with Sticklers, because they have mid-face hypoplasia, they can look like Pierre-Robin patients, but they're very different one from the other. Among the craniosynostosis, probably these are the most important ones, and among Crouzons, they have very shallow orbits with exposure. Upper syndrome, they have syndactyly. They can look like Crouzon, but they have syndactyly. And Pfeiffer, short thumbs. Fetal alcohol syndrome. Most important for fetal alcohol syndrome, the most important complication is optic nerve hypoplasia. Fascias, they have something very characteristic, and they have a flat philtrum. That's actually it's right here. And that's characteristic of fetal alcohol syndrome. Ocular albinism. So we have ocular albinism and oculocutaneous and ocular albinism. Thyrosinase are negative and positive, both autosomal recessive. Oculocutaneous albinism characterized by complete absence of pigment. Ocular albinism is less severe, and there's just decreased pigmentation in the retina. But the most important is macular hypoplasia. And that's the reason for poor visual acuity in patients with ocular albinism. It's nothing else. So just remember that. These two, I think, are very important for you to remember. I don't know if for board examination, but I think for your life. Because there are two entities that are associated with ocular albinism. One is Chidia-Higashi, where basically the patient had increased risk of infections. And the second one, Hermansky-Pudrak, which is high risk for bleeding. Aicardi syndrome. Aicardi syndrome is characterized by these findings here that basically you see here. They have, actually, the optic nerve, if you remember the picture that we just saw a few minutes ago, this is like a morning glory type of anomaly. And that's characteristic of Aicardi. But what is really characteristic of this patient are all these lesions that are all over the retina. These chorioretinal lacunae or colobomas that are multiple are the characteristic findings of Aicardi syndrome associated to infantile spasms and midline defects. Remember that boys will die when I have Aicardi syndrome because it's an X-linked dominant condition. Infectious diseases. So ophthalmia neuratarum, so just the days of presentation, and I'm just going to emphasize one of them. So toxic is usually the first one. We don't see that many often now because we don't use something that was used a long time ago before probably you were born, most of you guys. It's called silver nitrate. And that was one of the reasons to cause toxic conjunctivitis. Neisseria gonorrhoeae, it's in the first 7 days of life, very severe, extremely severe. Bacterial is usually in the first week. Herpes is later. The one that I want to mention and I want to emphasize the most is chlamydia. Because chlamydia is probably the most common disease that can be present at birth in the canal for these kids. It presents late, usually 2 weeks after. But when it presents, the risk for this kid is atypical or interstitial pneumonia several weeks or even months later. So the diagnosis that you actually make 2 weeks later of possible chlamydia conjunctivitis can maybe save the life of this kid, or at least some people even suggest prophylactic treatment systemic treatment for chlamydia on these babies to prevent pneumonia. Lacrimal system. Of course, the most common one is nasal lacrimal duct obstruction. About 20% of newborns have this condition. Usually it's due to the Hasner valve, but 90% of the times it's open before the first year of life. And the treatment of choice is none. We wait until it's open in the first year, unless there are recurrent infections or when you have a dacryocyli. Because when you have a dacryocyli, there is a distal obstruction and also a proximal obstruction. So the lacrimal sac is distended, bluish, and you have to drain in order to improve the condition. So probably doing an early probing will just solve the problem. Okay, for tumors, I'm just going to talk a little bit about retinoblastoma, which is the most common tumor, malignant tumor in the childhood. It presents in the first 4 years of life, and it has great survival, probably thanks to Dr. Lynn Murphy at Children's Hospital, because he's done most of the research on this disease. Retinoblastoma is due to a mutation on a gene that is protective. And it was actually the first gene that was ever described that will cause cancer, the gene for retinoblastoma. So there are two forms to have retinoblastoma. One is inherited, where basically there is a base mutation, that is a germinal mutation, and then there is a second mutation that needs to happen. So then it will cause basically the tumor. The non-inherited will have two mutations, somatic mutation, and then you will have a tumor. And why is this important? Because usually inherited, which is what you have to remember, is inherited retinoblastoma happens earlier than non-inherited. This one is usually multiple tumors and is usually bilateral. The non-inherited is usually unilateral, single tumor, and later age of presentation. The most common cause of death in a patient with retinoblastoma is not retinoblastoma, is sarcomas. And the most common is osteosarcoma. And I'm going to explain what is the theory behind, if ever somebody asks you. It's probably one, because these other tumors are genetically codified near the the gene for retinoblastoma. But the other thing is that patients with retinoblastoma were usually treated with radiotherapy, and that probably increased the risk for these secondary tumors to develop. When patients die from retinoblastoma, it's either because they have metastases that can grow from the optic nerve on tumors that are called exophytic. I'm going to show you a picture of an exophytic tumor. Exophytic tumor, they grow subretinal. They don't grow inside of the eye. They grow outside. And the way they metastasize is through the optic nerve. So when we treat patients and we do enucleations, the clue is that the margins of the optic nerve are clear. If they're not, the patient is at risk of metastasis. The endophytic tumors, they grow inside. And those are the ones that will give you a lot of what we call vitreous seeding. They cause detachment. And they can actually grow by going into the anterior chamber, the angle, and just going out of the eye. So those are signs that actually are considered low prognostic factors. The typical pathology is what is called Flexner-Winter-Steiner rosette. This tumor that is elevated here, that is flat here, elevated, is an endophytic tumor causing a retinal detachment. These white spots that you see here is called vitreous seeding. Vitreous seeding is low prognostic factor because this is not reached by medications. This is usually reached by radiotherapy. maybe intraocular medication or some medication that is actually going into the ophthalmic artery can reach this vitreous seeding, but the normal treatment usually doesn't get the vitreous seeding. The other one will be a tumor that is growing underneath the retina. It's called exophytic. Usually the metastases happen in the first 3 years of life, so patients with retinoblastoma should be followed up for the first probably 5 years until they're tumor-free. The most common sign of presentation is what you're seeing in this picture. Leukocoria is number 1, and strabismus is number 2. Differential diagnosis, well, the list is huge, but just think about leukocoria, retinal detachment, uveitis, toxocariasis. But most of the patients that were enucleated for retinoblastoma as diagnosed and then were read as no retinoblastoma, what do you think they had? Coats disease. And that's probably the most difficult diagnosis. So when we look for retinoblastoma, one of the things that we look for is calcifications. So when we do a CT scan or an ultrasound, we're looking for calcifications. That's very characteristic of retinoblastoma. The workup is basically a metastatic workup. And one of the things that we want to do is MRI scans, because a very low percentage of patients with retinoblastoma will have what is called trilateral retinoblastoma, which is a primary tumor, no metastasis, but primary tumor in the pineal gland. It's called trilateral retinoblastoma. Now, this classification is the new classification for the treatment of the disease, basically. And this is created by Dr. Lynn Murphy at Children's Hospital, LA, and USC. And it's basically it's for prognosis. Small tumors without involving the macula, group A, and a group E is the tumor with a high risk. This tumor needs to be enucleated. Most of the patients with retinoblastoma now don't need enucleation. The treatment of choice is probably chemotherapy and focal treatment, which means laser, sometimes cryotherapy. And the high-risk findings for this tumor is basically extension into the optic nerve or extension into the anterior chamber. Follow-up is examination under anesthesia. And last, retinopathy of prematurity. I'm going to talk just a little bit about this. The most important risk factor for retinopathy of prematurity is, of course, prematurity. And the age, remember, less than 32 weeks. And the weight, less than 1,500 grams. Exposure to oxygen, but it's not oxygen itself what is going to really increase the chances of retinopathy of prematurity. It's probably the fluctuation between 100% saturation and desaturation. And because of that, a lot of people, including Dr. Wright, I don't know if he's here, or maybe he's coming later, he did a study in Duke University too, where if you keep the levels of oxygen not as 100% but less, you decrease the chances of retinopathy of prematurity. So these are the kids. Usually happens 4 to 6 weeks after birth. So it's when you should start doing a screening. And the frequency of the screening is based on what you see, but probably every week. And if you see something that is aggressive, it should be probably every other day. And we divide retinopathy of prematurity in stage, zone, and extension. And the last thing is plus disease. So let's try to elaborate this a little bit. We have a demarcated line. This is what we call stage 1. When this line becomes thicker, basically, is what we call stage 2. And when you start seeing some vascular proliferation, some tufts in here, this is stage 3. Stage 4 and stage 5 are basically retinal detachment. 4 is subtotal retinal detachment. with the fovea attached, and 4B with the fovea detached, and 5 is a fonal retinal detachment that can be opened anteriorly or posteriorly, or open posteriorly but anteriorly closed. Now, zone 1, zone 2, and zone 3. If you take the optic nerve as the center, and then you take two diameters between the fovea and the disc, those two diameters will determine what is zone 1. Zone 2 is basically up to the aura on the nasal side that will be basically anterior to the equator at the temporal side. So you don't have zone 3 on the nasal retina. Remember that. There's no zone 3 nasal ROP. It has to be temporal. That's this island that is left in the temporal retina. And the last part will be what we call Ploss disease. And basically Ploss disease is artery tortuosity, vein congestion, iris engorgement, and inability to dilate the pupil in hazy view, of course. So this is Ploss disease. So now we move from treating patients that were basically threshold disease, basically when they have Ploss, into much earlier treatment because that probably improved the prognosis of these babies. This is Ploss disease. Severe vascular tortuosity, venous dilation. And the last thing is extension. 5 contiguous hours or 8 non-contiguous hours will determine that you should treat the patient, basically. So now, when we treat patients with ROP, these are the patients that we will treat. Any patient in zone 1 or 2 that has stage 3, especially with Ploss disease. Close observation, patients in zone 1 that have stage 1 and 2 with no Ploss disease, or patients in zone 2, stage 2 or 3, or patients in zone 3. Basically, those are patients that we observe. All the other patients will probably need to have treatment. Complications. When I follow patients with retinopathy of prematurity, I basically tell parents, your kid will have myopia, because that's basically what is going to happen. Almost all these kids have myopia. They have lenticular myopia. Remember that, lenticular. And they have, of course, the risk of retinal detachment. Of course, when they're treated with laser, probably that decreases the chances, or you're basically doing retinopexy